Um, my name is Dr. Clement. Today I'll be doing the management of a migraine. I've already introduced the migraine as being, if it has an aura, as being a classic migraine. If it doesn't have an aura, it's referred to as a common migraine. Now today, we're going to have a look at just the management of a migraine. Very discomforting headache. What is the plan? How are we going to look at this? The management of a migraine. We said migraines, for instance, these are your children, your adolescents, anyone less than 40. We seldom get it after 40. But at less than 40, your daughter, your son, it's a problem of a parent, so to say. You don't know what to do. Now, this is the plan. We are going to look at the headache, at a migraine headache. How do we abort it? How do we stop it? And we're going to look at how we prevent it. Prophylactic therapy, preventative therapy, so to say. So that's the plan. So first of all, how do we abort it? What is the first line therapy of a migraine? What's the first choice? First choice are triptans. We do have agotamine. We do have midrine. No, that's not the first line. The first line are the triptans. Triptans, some people refer to the triptans as the 5-HT agonists, receptor agonists. When you say HT, hydroxytryptamine, these are the ones, these are the new ones. These are the ones which will abort or stop a migraine. Do we have an example of an 5-HT receptor agonist? Yes, we do. Sumatriptan, for instance. And you would like to know, how do we use this? We can use it subcutaneously. We just use 6 milligrams. We can use it nasally. We use 30 milligrams. We can use it orally, which is the normal one, 50 milligrams. Then you've got it. You say sumatriptan. Is that the only one? Is that the only 5-HT receptor agonist? No. We do have others. They refer to them as the Zera or Zerna, because it is zolmitriptan. Zolmitriptan, which is similar to sumatriptan. Zolmitriptan And that's for Z. R, rizapine. It's a trypsin as well. Rizatriptan. And the E is for L-trypsin. And the last one, the naratriptan. Those are the tryptins. That's the first line. First line. You go for those, then you will not go wrong. You'll be able to abort a migraine. Then you have to say to me, is that the only way in which you would manage this patient? A glutamine, yes, you can use a glutamine, but you're not going to use a glutamine with a tryptin, any of the tryptins that I've mentioned. Sumatriptan, sulpitriptan. You're not going to use it with that. You're not going to use it with the rizatriptan. You're not going to use it with elatriptan. You're not going to use it with naratriptan. No, not at all. You're not going to use it with that. A glutamine has got to be used without the tryptins. The reason why you can't use it with the tryptins is because a glutamine, if you use it with the tryptins, they'll disturb the heart. If the patient has got heart problems already, you cannot use those. That's why you have to have a first line. First line are the tryptins. A glutamine, yes, you can use it together with migraine. Migraine has got 3 factors which are important to emphasize. It can be a muscle relaxant. It has a component of a vasospasm. It has got a vasospasm component, and it has got acetaminophen. Acetaminophen is like Panado. Panado. You know, you can use Panado 1 gram TDS or 500 milligrams TDS, depending on the intensity of the headache. You can go on and use another aborter, something that will abort the headache. They call it methysergide. Methysergide, these days it's no longer used. But if you want to use it, you must use it 3 months, but that 3 months must be followed by a drug holiday. It's called methysergide. Methysergide is very good in the sense that it's a vasoconstrictor, and at the same time, being a vasoconstrictor, it is a serotonin agonist. Serotonin is we like it. We like to mention it because serotonin is referred to as a hormone it's a happy hormone. So if the hormone is deficient, it is not there. So you are not going to be happy, that's for sure. And that is why we use it in migraines. Why serotonin agonists, anything that has got serotonin, that's going to increase the levels of serotonin because that's a happy chemical. It's a happy hormone. So methysergide has got 2 components. It's a vasoconstrictor. Why vasoconstrictor? Why vasoconstrictor? Vasoconstrictor because a headache is caused by vasodilation. So you want something that goes against vasodilation, which is a vasoconstrictor, and you've got your methoxsazide. Man, why don't we use it as first line? This one has got very bad side effects. It has got retroperitoneal fibrosis as a very serious side effect. I mean, you don't want to give treatment only to precipitate a retroperitoneal fibrosis. You don't want that. The peritoneum, it develops fibrosis. How is it going to contract? Fibrosis. So we don't want that. And that is why, but we insist on using it because you need to have 3 months of treatment and a drug holiday. You stop the treatment for a whole month. You don't use it. So it's used in staccatos like that. It's used like with a drug holiday. That's why it's not used. That's why the tractins are so important. If they can abort the headache, then you can forget about thiazide. You can forget about it because you've got something that will abort the headache, which will abort the headache and stop the headache. Of course, you still have a glutamine. You still have migraine. Those you use them after you have used your triptans. Your triptans are the first ones you're going to use. The first ones you're going to use. So this is what is important about aborting a headache, stopping a headache. I'm talking about a migraine in particular. I said the plan is to look at prophylactic therapy as well, that is preventative therapy. How do we prevent this? We have to think of a group of drugs, tricyclic antidepressants, beta blockers, calcium channel blockers, and sodium valproate. That's epilene, sodium valproate. But the tricyclic antidepressants, you're not using them as antidepressants. In other words, they're independent of the antidepressant effect. The sodium valproate is an epilene. That's an anticonvulsant. But you want to use it independently of the anticonvulsant effect. You don't want, you're not trying to cure convulsions. You're not trying to cure depression. And so that's why now the dosage is so important. For instance, with the antidepressants, we always like to use 25 milligrams at bedtime. And if we increase it to more than 100, we get worried about, the patient, the patient, of course, the patient will sleep, and the tendency will be, the patient will always be like drowsy and all that. So that's a problem with that. That is why you have to go for lower dosages like 25 milligrams. In anticonvulsants, we normally use as an anticonvulsant something like sodium valproate, for instance, 200 milligrams, and we go up even 2 times a day. But now with these, we go up. We can even go up to 300, we go to 400, 500, and all that. But when we're treating a convulsion, we're not treating a convulsion. We're trying to use it as prophylactic therapy for a migraine. And if you use 125 milligrams, that's fine, man. That's fine. 125 milligrams, that's fine. You use it for, you are not using it as an anticonvulsant. You are using it as a what? You are using it as a prophylactic therapy or as a preventative therapy for a migraine. So you have those two. Is there any other thing else that you can sort of use as preventative therapy? Yes, the beta blockers, the calcium channel blockers. Let's talk about beta blockers. Beta blockers, hey. Beta blockers, first of all, what do you use a beta blocker for? To block the P waves coming from the upper chamber of the heart, going through the AV node. AV node that's your atrioventricular node, which is a border gate before you get to the ventricles. Right. So you want to stop. You don't want anything that causes fast heart rate. So a beta blocker is used for that. You don't want anything that causes a fast heart rate, tachycardia, so to say. But now you're using it as prophylactic therapy for a preventative therapy for a migraine. So you want to make sure, beta blockers, of course, you have to get worried about the pulse, so to say. When you're using a beta blocker, you are already worried about the pulse. You are saying the pulse is very high. And so let's block anything that generates those rapid contractions of the ventricle. You want to prevent that. So in other words, you must block whatever comes from the upper chamber going through the AV node. Block it so that you have few of them going through and produce a normal ventricular contraction and not a tachycardia. That's what you aim to do when you use a beta blocker. But now you're using it for, so you want to make sure that the pulse doesn't go, you don't stop it to an extent that it causes a bradycardia or a slow heart rate. You don't want that. How will you know? You need to monitor the pulse as not going beyond or going below 60 beats per minute. You don't want it to go, because when it goes to below 60 beats per minute, 59, 50 and all that, that's already a bradycardia. You don't want that. So you don't want to precipitate the bradycardia. Yeah, you want to make sure that. But then you ask yourself, when you're using these beta blockers, which beta blocker are you using? The one that is used, and it's so safe, it's used all the time, is what is known as propranolol. Propranolol. Hey, propranolol is good. 80 milligrams, long acting. You use it at night. You can increase this to double the amount, to 160 milligrams. But now get worried about your what? About your pulse. Is your pulse above 60? If it's above 60, good. If it's below 60, no good. So you can't use 160 milligrams. Rather use 80 milligrams. Yes. So people who are doing aerobic exercises and all that, they normally get their pulses going up. They can go to 160 and all that. But that is why it is important to ask the patient whether the patient is engaged in aerobic exercises, because you know that you're going to use a beta blocker here, which is going to stop that pulse going up. Because they do that because their pulses will go up if they, well, of course, any exercise, you are introducing adrenaline. So adrenaline is going to increase the heart rate. But then now, for those patients who are using a beta blocker, for the migraine now, you want to make sure that this, whatever I do, it must be such that the pulse doesn't go down to an extent of getting to below 60. Because if it goes below 60, that's a bradycardia, and that's not what you want. You don't want to move to extremes, move from a tachycardia to a bradycardia. No. You want a normal cardia. You want normal heart rate. In other words, heart rate has got to be between 60 and 100. You don't want anything beyond 100. You don't want anything below 60. That's what you want. So when you are using prophylaxis, but now, that is not what worries us with propranolol. What worries us with propranolol is the type of beta blocker that it is. Beta blocker, you would love that the beta blocker should be cardioselective. In other words, go straight to the beta 1 receptors which are in the heart, and not go to the beta 2 receptors which are in the periphery, like the lung, for instance. Because if they go to the lung, if the beta blocker goes to the lung, and you don't know whether the patient has got a bronchospastic condition like COPD, like chronic obstructive pulmonary disease, you don't know whether the patient has got asthma. You don't know that. That's why it's important to take history and find out what medication are you taking. If the patient tells you that, no, I'm taking my pumps, then you are not going to use that beta blocker that is non-cardioselective. And selection is, with propranolol, for instance, propranolol is definitely not cardioselective. It is definitely not cardioselective. It's worse. Now we're talking of higher doses like 160 and all that. We know that as the more you go up with the dosage, the more the drug loses its cardioselectivity. In other words, it don't go to the heart. It can go to the periphery, it can go to the lung, and you don't want that because it's going to cause a bronchospasm. A bronchospasm which will make the patient not to be able to breathe. You don't want that. You want to treat a migraine here. You want prophylactic therapy of a migraine, right? That's a beta blocker. So with a beta blocker, you are worried about cardioselectivity, knowing that propranolol, long-acting, is definitely not cardioselective. But for other patients who don't have this problem of asthma, who don't have a COPD, chronic obstructive pulmonary disease, who don't have that, it's okay. It does well. It will do well as prophylactic therapy, as preventative therapy for a migraine. It will do well. But when it comes, you've got to know this, that I am using a beta blocker, and the beta blocker has got to be cardioselective to work well. Because if it is not cardioselective, it goes to the periphery, to the beta 2 receptors. Beta 2 receptors we don't want. We want to go to the beta 1 receptors which are in the heart and not in the periphery or in the lung in particular. We don't want that. Then we can go over to other drugs which are used as preventative therapy or as prophylactic therapy. And these are the calcium channel blockers. Calcium channel blockers are actually categorized into two. We've got the dihydropyrimidines. We've got the non-dihydropyrimidines. The dihydropyrimidines, we don't use, we use them when the non-dihydropyrimidines have failed. Which are the non-dihydropyrimidines we're talking about? We're talking about verapamil. Well, For a headache, for as prophylactic therapy, we only think of verapamil. Verapamil is powerful. Of course, we've got cardizem. Cardizem is not for that. It's for high blood pressure and things like that. It's not for this, right? But verapamil tends to be wonderful. It works very well. It works very, very well, verapamil. But one has to know that verapamil is the type of drug that has got a negative inotropic effect. What is that? No, it is the type of drug which will not support the contraction of the heart. So if the heart has got a problem already, then the use of verapamil becomes a problem. So you use it, you have to check the patient whether the patient has got a heart problem or not. So ECGs have got to be done to make sure that the patient doesn't have a heart problem. Yeah, you need to do that. So this only if verapamil is not working, in other words, the non-dihydropyrimidines are not working. If the verapamil is not working, it's only then that you go to the dihydropyrimidines, that is nifedipine and nicardipine. Then you can go to those. 30 milligrams, for instance, of nifedipine. We normally use 60 for high blood pressure and all that, but here you can use 30 milligrams. It's just a prophylactic therapy for a migraine. And then you can go to nicardipine, which you can use, from 20 to 60 milligrams. And you only use when the verapamil is not working. In other words, the non-hydropyrimidines are not working. That's that. I think you must have learned something. And if there are any questions, I would welcome them in my YouTube channel. Thank you very much.